Hi, friends. My name is Erin Goodwin, and I'm going to do the study of obsessive compulsive disorder, also known as OCD. Um, I'm sorry that I'm doing my recording this way. Unfortunately, my computer, I don't know what it is. I don't know if it's me. I don't know if it's a computer or what, but I'm having a hard time recording myself, sharing my screen. I'm definitely going to have to look into it, but I just wanted to get this submitted sooner than later. But I do a print off of my PowerPoint. I went ahead and printed it off, and so I'm going to go ahead and just reference off of that as we go. But okay, let's get started here. The introduction. So, obsessive compulsive disorder is characterized by exclusive thoughts and fears which lead into obsessions. OCD is a very common disorder, way more common than what I even knew. It actually affects around 3 million American adults each year. Persons who have OCD often display unusual levels of metabolic activity in the frontal lobe and basal ganglia of the brain. Just some more interesting facts. Males have an earlier onset of OCD than females do and are more likely to have a comorbid tic disorder to go along with their OCD symptoms. It is shown in studies that family history may increase the likelihood. If a child grows up with two parents who have OCD, the chances of that child growing up actually becomes greater. In fact, I was just watching a show, Hoarders, last night, and a mother definitely had, but she had like a very like a aggressive OCD hoarding. But her daughter grew up in that home, and when she turned 21, she's still with her mom, and she actually through those years became quite a hoarder herself. So I can definitely see where family history may increase the likelihood of that continuing behavior, even after the child leaves home. OCD is commonly seen between ages of 18 and 35. It's actually quite rare to see individuals be diagnosed with OCD after the age of 35. No studies have shown that I could find that has a cultural difference with OCD. That means people who have different cultures and whatnot, there's no studies that show that one culture has, a higher level of OCD than the others. There's quite a bit of research on one specific medication that treats OCD, and it's actually abbreviated as SRI, which stands for serotonin reuptake inhibitor. It is a medication utilized to treat OCD. However, 40 to 60% of individuals do not have a successful outcome with that medication. So I think it's still in trial and error state. It is indicated that many youth and young adults actually go misdiagnosed or undiagnosed with OCD. I was reading it's imperative that, if someone's showing an onset of OCD, it's imperative that that person gets the appropriate treatment at a younger age. If they can get treated and start therapeutic measures to help ease those behaviors or get it to minimal, it's important that happens, because the longer it lasts, the more fearful and the more compulsive that person can lead to be. Treatment barriers. I read that some of the barriers could be that there's a lack of therapists that specialize with OCD, that understand the side effects, just the disorder, the diagnoses as a whole, and then oftentimes the clients being able to access the therapist can also be a barrier. Also shows that a lot of people don't know or understand the diagnoses, so that can definitely be a treatment barrier as well. Some of the symptoms of OCD can either be obsessions or compulsions. Symptoms can be mild and gradually progress in severity. Stress worsens symptoms. Persistent, repeated, and unwanted thoughts are another symptom. Urges or images that are intrusive. Compulsive or realistic behaviors to get rid of the thoughts. compulsive or ritualistic behaviors to get rid of the thoughts. So they have that means that they have those thoughts, those negative thoughts, and some people turn to like religion and like rituals and stuff to get those thoughts and whatnot out of their head. Sometimes they often think that maybe they're like possessed almost by the devil or some form of negative thing or person, if you will. People who have OCD can often have bad tempers, and in some cases, the environment can also play a role in the increase of OCD behaviors. It is commonly seen in persons who have been physically or sexually abused that their triggers for their OCD is actually environmental. Not always, but that is shown that, like I said, the environment does play a huge factor in people's triggers. Suicide risk is shown in about half of the people with this diagnosis. This is most seen when people are also diagnosed with an underlying form of major depressive disorder. So yeah, suicide with persons who have OCD is definitely not unheard of. So getting into like the short-term and long-term goals. The short-term goals that turn into long-term goals is to definitely identify the triggers. That could be anything. I mean, anything could be a trigger for a person, even without OCD. But again, it's important to identify the triggers to first begin to have adequate treatment. And then going out long term, it would be important to have the less amount of time spent focused on obsessive thoughts and performing compulsive behaviors. So 1, to identify the triggers, and then 2, long term would be to focus on positive things, don't exclude those thoughts and behaviors away, because then that person just becomes more fearful of that, but just to not focus so much. I hope that makes sense. Treatment options. Cognitive behavioral therapy, CBT. This is a form of psychotherapy. It gives tools to think, act, and relief. Exposure and response prevention. This is similar to CBT. However, this exposes clients to the things that trigger their anxiety in baby steps. This is not something that you just throw that client into, and this is gradually baby stepping this person into the things that trigger them. And that's what exposure therapy does. Acceptance and commitment therapy, also known as ACT. Medication. A lot of times OCD is treated with antidepressants. It's actually one of the first medications that go into treatment of OCD. Because, like I said before, a lot of patients with OCD have underlying depressive disorders. That could be, PTSD. That could be, any form, just a mild form. But typically, OCD is stemming from the underlying depressive disorders that client has. Motivational interviewing. This form of therapy, the therapist in a supportive way, this form of therapy engages the therapist in a supportive way while supporting the client in discovering new tools for managing symptoms related to OCD. Of course, the treatment goal would be just to not have those triggers, but it's not that simple. They're gonna have those triggers, and it's just the way that it's treated and the way that therapists and psychologists and all that can help those clients minimize the outcome of being triggered. So I put on here that therapist will help the client desensitize and relearn new and improved skills. It's very important, I think. This will also, in return, lessen the symptoms of OCD. I pulled the diagnostic criteria out of the DSM-5 just to add in some more information on the diagnoses or the behavior. So it says recurrent and persistent thoughts, urges, or images that are experienced at some time during the disturbance as intrusive or unwanted, and that is in most individuals causes marked anxiety or distress. The individual's attempt to ignore or suppress the thoughts, urges, or images, or to neutralize them with some other thoughts or action. Example, by performing a compulsion. So here are some examples of OCD. Hoarding is one of them. They fear that, there's different reasons behind hoarding. One, they could be fearful of, the world ending and, a zombie apocalypse or whatever the case is. They have to hoard and continue to keep things that's going to help them in the future. Or I have seen persons actually hoard in the sense that if they throw something away, they're going to be punished somehow. That goes back to, them seeing the thoughts and having the fears and whatnot. They simply cannot throw, and when if someone was there, a therapist or a family member, to help them actually start the process of deminimalizing the items that they have in the house, that can be a trigger. That is a trigger. That can be a significant ordeal for that person. So it would be very important to have appropriate persons there to be able to help minimize that and help them cope in a healthy manner. I've watched a movie. I cannot think of the name of the movie, but another example of OCD was the man, before he could leave his house, he had to touch the handle, pull back, touch the handle, pull back, touch the handle, pull back. I've seen in other cases where the person wants to lock up for the night or whatever, they go and they lock the door, unlock it, lock the door, unlock it, and etc. So it's just those behaviors. It's not necessary, but they think it is. So it can actually put a damper on, their daily functions. It can, cause, in most cases, it does cause significant healthy lifestyles. Sorry. Like I said before, it is definitely a key factor to identify those triggers. Again, not to ignore the triggers, because if you ignore them, that person will then become more fearful of that, and they'll never be able to appropriately cope with those triggers. So identify them and then work through them with a skilled psychologist or therapist or whatever say you. I think that was about it. I pulled a lot of my material from the DSM-5, and then I also went on to the WebMD, where I found a lot of interesting deals. So if you have any questions or want to talk more about it or whatever, then definitely email me or comment on the video. I do apologize. I tend to stutter and I tend to misread my print. I get kind of stage fright. That's one of my fears. So I hope that my presentation was interesting and you learned something from it. I hope you all are staying safe, and I look forward to hearing from you guys. Thank you.